I'm very pleased to welcome you to the Oregon Health Forum Breakfast. We're going to be talking about the future of CCO, and I'm so glad you're all here. It's wonderful having these monthly breakfast forums that we initiated about a year ago, and we will continue doing them. I want to acknowledge our sponsors that help our nonprofit bring together the thought leaders in Oregon healthcare to discuss our most challenging issues. Please join me in thanking the following: Advantage Dental, Care Oregon, Kaiser Permanente, and Performance Health Technology. If your organization is interested in becoming a sponsor, we're pleased to have a new person on board our staff, Kelly Jensen, who's in the back, and who'll be happy to talk to you about this opportunity. Also, we started a new little project of bringing students in to basically not asking them to pay, but having them as our guests through our sponsorship opportunities. And today, we have students from OHSU and Linfield. I don't know if they want to stand and acknowledge who they are. It would be great to have them stand if they're around. We'll be inviting students every month to join the discussion. Next month, on March 22nd, we're bringing leaders from DC to discuss federal health reform efforts. There's a flyer on your table. Just a few ground rules. After the presentations led by Greg Van Pelt, you'll have an opportunity to ask questions. There's a microphone in the audience. There are note cards on your table that our staff will pick up. Also, before you leave, please complete the survey that's on your table so we can make sure we bring you the most worthwhile programs in the future. Now it gives me great pleasure to introduce our moderator today, Greg Van Pelt, President of the Oregon Health Leadership Council. Thank you, Greg.
Well, good morning, everyone. It's great to see so many friends and colleagues with us today. We hope this is helpful, provides some insight, and also we have some fun. Our goal is to learn from colleagues who really are on the front line, their experience, specific expectations, and recommendations as we go forward. Some of our ground rules we'll use about 45 minutes or so in terms of panel back and forth in terms of questions, and we'll open it up to the audience. I will do my best to direct specific questions and also time keep a little bit as we move along. Our context, it's not many secrets out there. Budget challenges at the state level, just complete unknowns at the federal level. Our CCO model is still evolving. The business community is anxious about the return of Medicaid cost shift, and there's pharmacy and other cost drivers that are challenging all of us. So this is the context we're operating in. There's one thing, though, that I can say about Oregon, and having been part of this medical community, this healthcare community for so many years, if we make our minds up to do something, and culturally, if we start kind of together, grassroots, and figure out what it is we want to do, we usually figure out how. I have the utmost respect for each of our colleagues, and I'm going to just go across the table and introduce them. You have their full bio at the table. But again, it's just been a real privilege to work with each and every one of them over these years. First is Gail Evans, and the one word I would use to describe her is engaged. It's really easy for the business community to check out on occasion. Say, well, we got that solved, we'll move on to something else. But Gail stays engaged and keeps us kind of the guardrails as to how we collaborate and how we keep the business community in mind. Chris Ellerton. Chris also serves on our Oregon Health Leadership Council board. Chris is thoughtful. He's been very helpful to me over the years and takes his time to think through things before taking action. Next, Jeff Hetherington, and this is in his bio. Those of us who know Jeff, unwavering. I think that describes Jeff. And again, he'd been at this a long time in this state, has tremendous experience. And then also, relatively new to our community, Eric Hunter. And there I would describe Eric as experienced. He brings a wealth of knowledge from around the country, and can add to the ideas that we've been thinking about working on for a long time. And then finally, Lynn Saxton, who I would describe and described in her bio as community and civic leadership. Lynn is one of these people that does this because it's the right thing to do. She has worked in public, in private, and in social services, and just is here for the right reason. So that's our bench, and let's get started. And I'm going to start with Lynn. Lynn, again, you jumped into this work with both feet, both arms. What's your take on the performance and confidence in our model going forward?
Thank you, Greg. Good morning, everyone. I have complete confidence in our model going forward, fundamentally because of the reason Greg just gave. Is in Oregon, when we make up our mind to do something, we do it. We have been transforming healthcare in this state for 20 years. I was an early adopter of the prioritized list, boring many of my friends and families in 1994 by talking relentlessly at how savvy that was to take that approach to healthcare. And what I have seen in the last 2 years working intensely with our 16 CCOs is an absolute commitment to getting healthcare right. And it isn't easy. We've hit some bumps in the road. We have some big challenges in front of us today, but 3 years into the Affordable Care Act implementation, this state is leading the country in using evidence-based practice. We are 19th in the country, up from 30-something in providing access to care. 95% of Oregonians have access to health care or insurance, and 98% of children, and hopefully 100% this year, have access to care. And that is truly remarkable. So I'll stop there, but I do want to say, I hope we talk today about some of the foundational elements that Oregon has built into its healthcare system that I think are the cornerstone of success going forward in a more complicated federal environment.
Thank you, Lynn. And we will welcome kind of point, counterpoint. I'll try to manage it if we need to. Eric, you're new to Oregon. What do you see that's working? What's not? What's some advice for us?
Thanks, Craig. As far as what's working, I was sort of lucky to get the opportunity to come to Oregon. As Greg mentioned, I've worked in Medicaid, Medicare, commercial, behavioral health in a dozen states over the years. This is different. And I don't say that because I'm here, I say it because it's true. The collaboration amongst the partners here is something I've never seen before. I'm used to a healthcare environment that's much more competitive and cutthroat and dog eat dog, and how do we compete for members, and how do we compete for patients, and how do we fight for those scarce dollars. What I'm encouraged by historically and hopefully in the future is the ability of the system to come together and say what's in the common good for the folks that are most vulnerable. I mean, that's what hopefully this is all about. And I think there are great examples across the board, just systemically, and even Jeff here with Family Care and Health Share work together on emergency transportation efforts and different things that, typically organizations like that aren't always linked in saying, hey, what's best for the community. So I think that's what works. I think the tough part and the scary part is everybody's going to hear talk quite a bit about is the dollars. How do you reconcile the challenges at the state level and the federal level, and sort of lack of clarity yet at the federal level, with the argument we make about the success we've had. How do we make that case so that it's really clear about what levers led to the success in Oregon, and what the impacts would be if there are sort of dramatic shifts in how it's funded. I think that's going to be the big challenge, because I've heard some folks in DC think that it's already a block grant state. Some people think we're ACOs. I mean, no one really knows what we are. They just know it works. So if we can get that message clear, then I think it'll have a much better chance of making sure that it continues going forward.
All right. Jeff, you've been at this a long time with family care. What's different in your career experience of where we are today, where we've been, and what are your hopes and expectations?
Well, a couple things. First of all, I would second what Lynn Saxton said. I don't think as Oregonians, we really recognize how far ahead we are in terms of healthcare and healthcare delivery. I've had the opportunity over the last number of years to talk to a lot of conferences nationwide, and I listen to other states talk about what they're doing, and they're having the conversations today that we had back in the early 1990s when we were still fashioning the Oregon Health Plan. And I think you sort of have to weep for that because they're that far behind. I think the things that are really good about Oregon, and a couple of things we ought to pay attention to is, number one, we have kept healthcare a nonpartisan issue in this state. There was a little bump back in 2003, but the bottom line is both the parties have worked pretty well together to keep the Oregon Health Plan alive and to keep it moving forward. And that's really important, and you should thank your legislator of either stripe for that. The other thing that I think that where we've kept our light under the bushel is with the prioritized list. It really is the most evidence-based benefit list in the country. And if we could patent it and sell it, we'd get rid of all of our budget problems. I think the budget, they're talking about the budget thing. I would throw out something that you might call something different than unwavering, but there's plenty of money for health care in this state. It is just a matter of redistributing it so that the people who need it get it, and the people who are making massive profits, and particularly in the provider area, learn to give up a little so that the rest of the population, particularly the Medicaid population, can be adequately served. I hear a lot of things about the budget crisis here in Oregon, and I tell legislators and I'll tell everybody here in the room, take a deeper look, because it's not as bad as it looks, and there is money there, but we need to redistribute it so that particularly the Medicaid population does not suffer from what is described.
Thank you, Jeff. Chris, a longtime exec in Oregon, relatively new to the CCO world. What do you like? What surprises you?
Yeah, so thanks, Greg. I'm just short of a year in and still learning new things every day. So it's fascinating and really, frankly, invigorating to have the opportunity. So much my career has been, I guess, in the private pay or commercial pay, or however you want to describe that category. And so, kind of the compare and contrast, a lot of great work going on amongst the private payers. Typically, a lot of how we try to affect change in that space is sort of entity by entity, and a provider entity here and there and so on. Great work, a lot of deep engagement, but sort of stands in contrast to the structure and capability of and the opportunity that exists on the CCO chassis. That private space, we end up kind of with this sort of crazy quotes of opportunities and change. In contrast, when I look at and really just reverberate back what this group already knows about the CCO structure, its potential is so much greater. Scale, when every third or fourth patient through the physician's door is coming from a CCO, that brings credibility and tangibility to the things we're trying to do together to affect change. When on the private side, you might be lucky to have every 10th or 20th patient through the door. That's pretty hard to garner attention and effort and motivation. So scale is a clear and simple but valuable element. The comprehensive nature of the program and the stakeholders that come to the effort. Again, if you think about my kind of crazy quilt analogy on the private side, we often don't achieve that comprehensiveness of the parties that it takes to affect change. And the governance model, in a private payer environment, provider X often thinks about a problem or a solution differently than provider Y, and you don't have the same governance opportunity to bring that issue and those providers to the table as you do in the CCO environment and get to a solution that works for the community. So those attributes, I think, stand out to me. The comparability, the fact that we have 16 systems all serving slightly nuanced communities, but highly measurable performance standards. We can compare, contrast, learn. Pretty rich structural opportunity. Surprises, I would just say that the complexity and the breadth of work that CCOs are asked to do is pretty astonishing to this guy. One of my early assignments was just to get to know my team and say, what do you do and how's your day go? We kind of inventoried committees and work groups and who was participating just inside our walls. And that was a sheet about this big. When we layered in the forums and the activity they're involved in their community, and then working with the OHA and the work groups there, you can imagine this, three-dimensional, dizzying set of things. I mean, some of my folks, I don't know that they necessarily need a desk. They need a laptop and a phone, and they could go from one meeting to another all day long, and just to cover all those responsibilities. So I'm really, humbled and intimidated by the work that the CCOs are responsible for, but in the same breath, really inspired. Really, I'm fascinated in the things I've learned, and it's a privilege to have the opportunity.
Thank you, Chris. Gail, the business community. What should we be thinking about?
Well, what are our expectations? I think long-term progress. We know that this is not going to turn around in just a couple of years. And the answer really varies by which business you ask. My involvement with the Oregon Business Association has given me a perspective to a range of businesses from very small, different parts of the state, to very large, fully self-insured. And they will weigh in differently to a lot of these questions. My perspective is really from the many years I've worked with the Oregon Business Association, in that we have been huge supporters of healthcare transformation in Oregon. The triple aim, even the formation of the exchange, sadly that did not work out very well. I think at this point, I've been very involved since 2008, and it's really hard to engage the business community because there is a level of fatigue that's setting in. Those of us who really bought into that transformation, we know the drivers of the cost of care. We're the private purchasers of healthcare. We insure millions of people in this state. We know what elements go into our premiums or the fees that we pay or self-insured or the reinsurance we buy on our plans. And so we wanted to see a shift, or at least bending the cost curve. You've heard that. We weren't expecting the cost shift to entirely abate, but we did want to see some movement in that curve. And so far, it's been pretty disappointing. We've seen charity care go down for hospitals, but we haven't seen any relief in the fee-for-services that get loaded into our premiums or our expenses. We see medical errors continuing. That adds about 10% to the cost of the care we provide for our employees. So malpractice, insurance, that gets loaded. So there's all these things that are loaded in, and we're trying to say, yes, let's look at this long term, but let's see some progress. And so far, the jury's still out, and meanwhile, many businesses have just taken matters into their own hands. You're going to see more defined contribution plans. You're going to see reference-based pricing increase. You're seeing businesses just simply try to get out of having to insure their employees, and so that's really sad. Somebody once told me as a mentor, the timing is everything. I hope we can see some progress soon, because I do believe in the model. I think a lot of businesses who are especially headquartered in Oregon really believe Oregon can figure this out and do it, and they're still on board. So I would just say, we understand this is sort of a startup. We understand, we like the creativity of CCOs. We like the local ability to tailor what's needed to your local community, and the whole concept of one barrier of care in rural Oregon is not the same barrier to care in Portland. And so I think the CCO model makes a lot of sense, and I think we need to still support it and see some progress.
Thank you. Thank you. Now, okay, those were the softballs. Now we'll try to dig a little bit deeper. And I'll start with Gail. Measure 97 failed. There's again these budget holes, and we're trying to figure out ways to fill them. Is the business community interested in helping participate in a revenue package to help fund healthcare, Gail?
First of all, I'd say we have already been participating to a great extent. The reinsurance pool, all of the various changes that we have supported, and yet we continue to see double-digit increases in premiums and costs for healthcare for our employees. And as I mentioned earlier, there's fatigue setting in. So what I would say from the business community that I work with is there is interest in a long-term sustainable solution. There is interest in how do we get through the short term, but we want to be creative about what the solutions are, not just trying to put together a revenue package, but looking at where are some sources of stable funding that can begin to form now. Our disappointment is largely in that the state knew this Medicaid shortfall was coming. And so coming to business now and say, oh my goodness, this last ditch measure didn't make it. Now what do we do? Help us. That just would not fly with most private boards of directors. So I think that there's some interest in helping to come up with a short-term solution if it really also leads to a long-term solution. But I think getting businesses engaged at this point is really going to be hit and miss. And it really, again, depends on who you ask, which businesses you ask that question of.
Thanks, Gail. Thanks for your continued involvement. It really is helpful to have that centering as we think through this from a healthcare perspective. Eric, as we look at total cost of care in this, all of us have struggled with this. How do we move upstream, the social determinants of health? How do we make those investments? What are your thoughts on that? How would we do that? Because at the same time, what is it? 25% of our population, Lynn, approximately, is in the Oregon Health Plan. We know there are these correlations between social determinants, and at the same time, our CCO is just trying to kind of make ends meet. How do we make new investments? Where would you invest? How would you do this?
Yeah, I thought you said that was the end of the softball. So I think social determinants historically have been sort of a space that at least Care Oregon and a lot of the CCOs have tried to be a part of. It's the integral part of what we do across the board. We recognized years ago that the solution to solving sort of long-term healthcare issues isn't just paying docs and DME and paying hospitals. It's getting ahead of the curve. It's heading things off before they happen. It's getting folks the right care at the right time, at the right place, all of that. I think we have to make adjustments if budget issues require it to make sure that we continue to have and support entities who are focused on housing. And that's one of the biggest issues that, it's obvious if anybody coming here has probably seen people that drove by them who have housing issues. Some might not even recognize people that might work for you have housing issues. Folks without stable housing, I think the numbers have said are 12 to 13% more expensive to the healthcare system than folks who do have stable housing. That's a big deal. Those are big numbers. Those change the dynamic of the entire system. I think making sure we deal with adverse childhood events so that children have an ability to go to school and stay in school and learn and have food security, and then that keeps them from going down a spiral, not just on the acute care side, but the behavioral health side and the oral health side. I hope it's preaching to the choir in that of all the things we have to do, if something has to give, organizations like Care Oregon, I know a lot of the CCOs, I would hope would continue to prioritize working with those community entities who are dedicated to upstream work. We don't necessarily need to do it ourselves. That's where That's where the balance comes in, but we need to be those facilitators, we need to be conveners, we need to have the collaborative efforts to say, how do we leverage the work that's already going on in the community to get more bang for the buck?
Thanks. Jeff, cost drivers. When you're struggling with investing in housing or some of the new drugs that can, in essence, wipe out your budget within a couple of years, what are your suggestions on the drivers and how we might impact those so we can invest in these social determinants?
So this is where Greg gets me in trouble, and I go willingly. You know, the real problem, I think, in terms of healthcare costs is that we've sort of transitioned from what was a caring community to a profit motivated community in healthcare. And if you take a look at, first of all, the drug companies, because, you know, the poster child now for greed in terms of what they're charging. Most of you may or may not understand that the generic prices have gone up almost 18% a year for the last 3 years. If you don't put a stop to that kind of inflation, then all of the downstream entities, including the insurance companies, really have nowhere to go. And it's up to the community actually to say, and I mean all of you and all of the business community, to say enough's enough. No one likes to hear the term price controls, but I think that's what we're looking at. I think we're looking at that in terms of pharmaceutical companies. I think we're looking at that in terms of hospitals. Hospitals costs go up 4% a year, easily. And, you know, with the hospitals having made a ton of money off of not having charity care in the last 3 years, we have not seen prices go down. We've seen them go up again. So why is it that we just continue to think that revenue is the best thing for every provider in healthcare and not stop it? That's my bottom line, because I think there's a bill in the legislature to put in a rate review committee. That's probably the wrong term for hospitals. I think that's necessary. If you take a look at the bottom line of hospitals, you always hear about their operating budgets. Take a look at their 990 forms and how much they're making. And then think about what the best stock is to invest in, which is pharmaceuticals. You know, we can't afford as a community to keep paying those costs. So I think that's where it starts.
Yeah, that's what we're looking for.
And there are certain medical providers I would put in the same category. But there's a lot of nuances to those, and I think, you know, we tend to blame the insurance companies, the commercial insurance companies.
Unwavering.
But, you know, the bottom line is an insurance company is just a pump. You know, it takes in money from one end and someone else turns the spigot at the other. So, you know, insurance companies, we all have our problems when we're insured, but basically we're just a pump.
Jeff, thank you. That's we say among our friends. Now we're having a conversation. Chris, Centene's been in this business a long time. What have you learned in their engagement? Any ideas that they're bringing to Oregon?
If I could just a quick trailer to Jeff's review there, would add maybe politely that you know, some of the problems we face in the, say, pharmaceutical challenge and trend would offer, some of those are good problems, right? We're looking real closely at our pharmacy spend, which is going like this, and within that, you see elements like the utilization of insulin going up. I think that's a really good problem to have, right? It adds to the challenge, but you know, I think that's if that's a problem, it's one I think we created and probably endorsed that we have more of our beneficiaries using insulin and using it regularly. So I think within the challenges we face, sometimes there are good challenges, right? And we can embrace those. But back to your question. First to echo, comments that Lynn and both Jeff made about how the world around Oregon looks at what's happened here. You asked the question about, what perspective or other experience that Centene brings. I think I'd start with the inverse. Both folks at Centene and other organizations, as Jeff mentioned, look at this model with great fondness and intrigue and appreciation. So when I started to get to know my colleagues at Centene that operate plans and programs across the country, they quickly, hi, I'm Fred, and tell me a little bit about how you're doing behavioral health integration. So what we're doing, what you all are doing is studied and marveled, and including my colleagues at Centene. So Centene operates and is engaged in programs in about half the states in the country, and they're all differently shaped and alike. One of the things I see when I get to know what's going on in other places, a lot of attention in the category of long-term services and supports, and I think some good work going on generally. Think about that in the Oregon context. Oregon is probably, again, well out ahead of most of the country in this program, and having really pushed forward on utilization of home community-based services, way out ahead of the rest of the country. So a lot of early momentum, but LTSS, as Lynn knows very well, it's a big program and a big expenditure for our state. I think the numbers, just to kind of give it a rough scale, for roughly about every $2 we spend on CCOs, we spend about $1 on LTSS, federal and state monies together, so it's big. The expenditure trend on that program in current years and future years are in the mid-teens. Those are, in most days, when we talk about trend in the mid-teens, it's a pretty startling piece of math. So we've got a big program with a challenging trajectory in front of it. We've got a good, solid base. It's not broken by any stretch, but those issues are, I think, important. Meanwhile, we have now 5 years of the CCO model and demonstrated the ability to coordinate, collaborate, and innovate. And so, thinking about what's happening in the world around us, thinking about our context here, what are our assets, it feels like, maybe it's time to kind of re-examine the role that the CCOs could have in helping a good program continue to thrive against a pretty challenging sort of fiscal outlook.
Good. Thank you, Chris. Lynn, this is as good as it gets. And we have these challenges in front of us, and our world might be upended. What's going on at the federal level? What should we be thinking about, planning about today?
Thank you for that question. I was in Washington, D.C. last week, and one of the things that I was thinking, first of all, the really good news here is that Alaska Airlines now has a direct flight from Washington, D.C., and it doesn't leave at 4 a.m., so I'm always grateful for little things. About 60 days before the election, our leadership team does a huddle on a regular basis, and about 60 days before the election I said, probably as a function of my age, because you get used to expect the unexpected, I said, Donald Trump could be elected president and we need to be ready. And there was this dead silence. And I said, I'm serious. We have a huge responsibility in the health of Oregonians, not just CCO health, but population health, so we need to be ready. And then the morning after the election at 6:30, we had a conference call of really getting ready. And so we started that work at 6:30 a.m. the morning after the election to be prepared to advocate for Oregon at the federal level. And so this trip last week was really the first phase of that work. We've had a team working again since the day after the election, preparing the data, preparing the messaging, the strategy for outreach and talking to people. And I think made a good start last week in communicating with the entire delegation as well as other interested people. First of all, in listening. It's really critical in the political process to understand where politicians are coming from. And I don't think any of us should ignore the fact that some of this discussion on the national level is about the budget. We want to talk about healthcare. We want to talk about healthcare transformation. But there are a significant number of members of Congress who want to talk about the federal budget. So when we visited, and I appreciate Jeff's comments that in Oregon, healthcare has been bipartisan for decades, and that serves us well in the current environment. But we talked about the fact that what Oregon has done is re-engineer healthcare. And a lot of the current conversations in Washington are about different ways to purchase or buy healthcare. They're not about re-engineering healthcare. And we talk to people about the importance of re-engineering healthcare if you're going to get a better result for your money. And I'm very sensitive to Gail, to your points today as well, that we do have that obligation and that need to show that overall the system can work. So first we talked about the coordinated care model, how that's different. Integrating behavioral health, physical health, and oral health really does produce a different result. For any of you who have read Secretary Price's plan, Speaker Ryan's plan, part of what they are interested in is getting a different result. And so I think we made a good case that you can't get a different result if you just keep doing the same thing and you fund it through block grants or you fund it through some of the other tax credits. One of the things that we all learn early on in life is that tax credits require income. And that's something that the current discussion needs to focus on. We've been doing some great modeling for members of Congress about what does it mean when you're on Medicaid? How much income do you have? What is your health care spend? So we also talked about slamming on the brakes and going in reverse in the midst of a startup. Particularly one such as Oregon's that is very well documented, both in terms of our failures and our successes. We were pretty transparent with everyone in DC about here's what's working. CCOs are working. Many of you saw Congressman Walden's quote in the paper and the media probably a week ago, maybe 2 weeks ago now, about gosh, we've got the CCO thing in Oregon and it's working. So we were able to advocate for that, the coordinated care model. We also said that changes need to be made to stabilize, not disrupt. To just go back to a fee-for-service, block grant, tax credit kind of incremental approach may provide some form of budget relief. And again, we have to be mindful of where politicians are coming to the discussion, not where we're coming to the discussion. But the greater interest here and the compelling case I think we were making is you have to look at the fact that Americans need access to health care. They need access to health care to work. They need access to health care to go to school. It's simply absurd to think about how you get people out of unemployment or how you get children out of poverty if they don't have access to what I consider a foundational need for their success. Now, I think we also saw a lot of uncertainty. I was sharing with someone earlier that I love Washington, D.C. I've spent a lot of time there in my life. They're on a different clock now, and you can see it in people's faces. You can see it in people's attention spans. You can see it in the level of anxiety or enthusiasm, depending on where they were post-election. Our job, the Oregon Health Authority's job, every day, from now until we secure the Oregon Health Plan, is to be available to both parties on an instant basis to get them the information they need. Fortunately, we have it. We have a well-documented healthcare system. But to get it to them before they make a precipitous decision which actually is not going to achieve their goal and isn't going to advance healthcare. And that's a huge challenge for all of us. I think in Oregon we have the legislature going right now. I think people are thinking in terms of months. Right now in Washington, D.C., people are thinking in terms of hours. And so our organization has, separated this work, allocated the resources to it, and we are going to, I'm not saying we're all getting Twitter feeds, but we are going to be ready to give people information that they need to make decisions, and we're going to be asking many of you in this room to help us do that, because they're running full bore, and we have to keep up. I want to finally say that we did make a very strong case with the delegation and with others in the healthcare field about the shared savings model that Oregon implemented with the 3.4% annual growth. There's a lot of discussion about caps right now. There's been some characterization of Oregon's model as a cap. We really view it as a shared savings plan. They're very interested in that. Oregon is one of the states that it's in our waiver for the next 5 years. That's different. Every state can't offer that. We're also talking about how the CCOs are responding in the partnership that we have to pay for value, pay for performance, pay for results. That's something, again, if you read the array of plans that the Republican Party has presented, whether you go back to Mitt Romney's plans or Paul Ryan's plans, part of the goal there was to get results for your healthcare investments, and we can demonstrate that because of the work of the CCOs and the innovation that we've had going on in Oregon. So I'm not a Pollyanna. I'm cautiously optimistic that we can, by being agile and listening carefully and proactive, create a go-forward model for Oregon's plan. It has to meet their goals as well as our goals. And again, I'm giving you all a heads up. We're going to be calling on you and asking you to support us with information. And I need everyone to be on board for instant response, because that's the pace that we're moving at.
Then thank you. And again, reminder that 1 in 4 of all of us are affected by this. And in fact, Oregon is the 4th highest state in the country dependent on federal funding for our Medicaid plan. So this is really important work. Thank you for what you're doing, Lynn. All right, well, let's open it up. I think we're going to have some microphones around the room. I see our hosts getting ready. And again, some of our ground rules, questions, not speeches. And I'll cut you off if I have to. All right, any questions, comments, suggestions, advice? These folks are doing this all day long. Yes, sir. And maybe tell us who you are and what your question is.
Good morning. Thank you for having me. I'm Neil Walker, community behavioral health advocate. I have a question for Ms. Saxton. What type of information are we needing to communicate to you and to communicate to the federal level on how to keep the Oregon Health Plan protected as well as move forward in your words?
Thank you for the question. And I'm excited that you're a behavioral health advocate. I consider myself a behavioral health advocate too. So I think the information they're looking for, again, I want to go back to this listening thing, because there's a really high level of political rhetoric right now. And so part of what we're being careful to do is, our governor has been very clear both in the budget process and going forward that we don't want to reduce benefits or the size of the Medicaid population. So the information we're trying to provide is, again, how the coordinated care model is working in Oregon with the CCOs, with the results that we can show at great levels of detail, and also to communicate success stories. Now, there is a website that's going live, and it is 95, if you go 95%, it'll pop up on your screen. And it gives you the opportunity to share stories of success around the state. We did a really nice presentation for every delegation, every congressional district, of exactly what the ACA has meant to employment and healthcare in their congressional district. You'll see some of that information. So that would be your best help, is to go on to that, and then we'll be reaching out through that as well to ask people for more details.
Thank you.
Thank you.
Sir.
Charlie Swanson from Healthcare for Oregon. The sale of Agate Resources, which is apparently Trillium to 17, involved what many feel is massive excess profit taking. What reforms in CCO governance or regulation would you suggest to prevent such misuse of funds in the future. And this is really.
All right, who wants to take that one?
It's a little unusual for me to take that one. But I will put in a little history here. Since the first Medicaid managed care program in Oregon, which started in 1985, the state's policy has been to allow both nonprofit and for-profit companies to organize to provide managed care. And we still have that system. They made that decision again when they put in the Oregon Health Plan, and they made that decision again when they formed the CCOs. Now there's a bill that Representative Greenlee has to make all of the CCOs not-for-profit. And family care happens to be a not-for-profit. We started that in 1985 because I'd seen doctors fight over money too much. And it wasn't gonna have that with our particular program. But those CCOs out there that are for-profit, they were built by people that put money in the bank out of their own pocket to form those CCOs. And it's just like putting money into a savings account, you expect a return. And the states allowed it. So I don't think anybody should blame the for-profit CCOs for their business model. If we want to change it, that's fine. But I don't think it is something where you blame Agate or Centene for selling their model to somebody else.
Chris?
You're welcome.
Charlie, thank you for the question. The way I think about the core, so obviously different philosophical views about things like corporate structure and tax responsibility and other attributes of CCOs, whether they're big, small, rural, urban, hospital influence, physician influence. Those are attributes of organizations. I think, meanwhile, all the CCOs have, I think, a pretty commonly understood and supported charter, and that's to achieve outcomes for the beneficiaries. I think that part's not like largely a debate, I think. So the outcomes we're responsible for, I think, are the important things. The attributes of our organizations are attributes. What matters, I think, to the beneficiary is the outcome. So a CCO that's achieving fundamentally the objectives of the AAA and those outcomes for the beneficiary, they ought to be celebrated, no matter their attribute, right? We ought to study them, we ought to envy them, no matter their attribute. And those CCOs that are not delivering on those outcomes, because it's the outcomes that matter, regardless of their attributes, we ought to critique them, and we ought to challenge them and say, you ought to be doing better. So I think at the end of the day, it's outcomes that matter to the beneficiary, not attributes of the organization. It's focus on getting the outcomes done, and I think that's what matters over the long course.
Yeah, I'd echo that. I think that, for-profit, not-for-profit, if you look nationwide, some of the largest entities in our country are not-for-profits, and they've got fleets of private jets and $20 million executive salaries. Not-for-profit, for-profit is, I think, not the issue. If you talk about accountability, it's making sure we maintain as much transparency as possible in the system. That community touch, the local governance of our systems, I think, is the key to all of this. It's holding all of us as CCOs accountable for meeting the needs of the community. So if that means that we need to spend more or less somewhere, and it's based on the community health improvement plan or based on the priorities set by the community, I think that's where you make the bang for the buck. The ultimate, as Chris says, the ultimate corporate structure, that's neither here nor there. It's still in there, still sort of free enterprise and all that. But where we hold folks accountable is in what they get done on our behalf. So I think we should focus more on that.
Yeah, what do you think, Karen?
I care. I think that there's positive creative tension that's created when you have both for-profit and not-for-profit mindsets at the table. I agree with Chris that it's really about the outcomes. As long as you don't have any unintended consequences or poor methods to get to those outcomes. You really have to have good governance to make sure that happens or doesn't happen. But I do think it's all about the outcomes. I think the business community wants to see that progress, wants to see the proof of concept, if you will, if it's to spread into the private sector. And so we would have a lot of confidence in a governance model that had that creative tension and mutual accountability.
I have a question here for Lynn. And you mentioned this, our trend commitment, our cap, we want to use that word, to 3.4%. We're starting to see trends now catch up with us. Can we get better, faster, cheaper?
We're about to find out. I think we can. I think one of the things that I would compliment the CCOs on is really working on that intensely. Whatever their business, their corporate structure is, they're all kind of driven to that and they take it very seriously. I think I'm pleased every time someone raises pharmaceutical costs. They are more than the elephant in the room. They're the hippopotamus, they're the rhinoceros, they're everything in the room. And our ability running a really first-rate health system in Oregon with all the discipline that we use is going to be futile in the face of the rising drug costs we're facing. So the challenge is before us, and it's about the heat's going to be turned up. I fully expect the heat will be turned up on the federal level.
Good, thank you. Yes, sir.
So I'm Howard Plank. I'm the project director for Housing and Services, have partnerships with a number of panelists. I want to applaud the work that's been done on social determinants of health. Oregon Health Authority's work through waiver and policy reform, the financial investments that have been made by Care Oregon and Family Care and Providence and Kaiser and many others in housing and food insecurity work in particular. The question I have this phrase that stuck in my mind about looking backwards through rose-colored glasses and how we take a view forward. The repeal or dismantling of the Affordable Care Act, the cuts that have been proposed for the Oregon Health Authority, the uncertain future, even with all the successes that we've had in Oregon, the risk that we have as a result of our Medicaid success. Pennsylvania, has 3 times the population and gets $1 billion less than we do. So the question, I'm working on the housing and health integration side. Many others are working on this cutting edge of social determinants of health in other areas. Where do you see things going with all of this uncertainty in terms of policy direction on social determinants to continue to allow us that flexibility and the financial investments that you all have made to encourage these partnerships, incentivize these partnerships? What advice do you give to us who are working on that social determinants of health arena in partnership with all the uncertainty that we're looking at going forward?
First of all, thank you for the work you're doing in housing. Housing is a crisis issue across the entire state. I travel extensively in Oregon, and one of the things I always want to tell people is it's a challenge in Grants Pass, it's a challenge in Portland, and it's critical to recovery and well-being of particularly the Medicaid population. I'm a political pragmatist, and part of what I just have to say is I don't think there is going to be as much money going forward. There is active discussion in Washington, D.C. of eliminating the Medicaid expansion population. In Oregon right now, that's around 360,000 Oregonians. So my advice to people is certainly, again, I'm going to go to that 95% website and making sure that you're weighing in and communicating successes. I think we are very much working very hard to ensure there is a replace model that supports the advances Oregon has made. The political pragmatism is 18 to 20 million people in this country have health care that did not have it before. And I don't take anything for granted in the House of Representatives. I do think there's been a number of senators on both sides of the aisle that have said there has to be a go-forward replace plan that ensures people have access to care. But I would not be doing anyone in this room a service to say that we have figured out the ongoing financing of both the Medicaid expansion population, and there's also some discussion of changing the ratios for the traditional Medicaid population in the states that didn't expand Medicaid. So I think we have our work cut out for us. I think part of our challenge, and we're committed to it, is responding on the state level to identify how we're going to pay for Medicaid at the state level, concurrent with very strong advocacy on the federal level that there are ways to replace that can build on. I like your example. I've constantly referred to our healthcare system as 1.0, and now we're in 2.0. And 2.0 has to be a little bit about not just replace, but repair and correct. So I think as long as we're candid about that, I think we can be successful, but I think the financial situation is very serious. And again, I'm going to go back to that. You need to listen to what people are saying. This is often described as a budget problem, not a healthcare problem.
Thank you, Lynn. Ken?
Good morning. My name is Ken Myers, and I work with HCAO, Healthcare for All Oregon. The legislature a few years ago created the CCO model and put it in the legislation. They also charged the Oregon Health Policy Board to create a plan using the CCO model, to get universal care for everybody in Oregon, affordable universal care. Is that plan still viable?
Thank you for the question. It's a question mark in my mind. I think the Health Policy Board, which is chaired by Zeke Smith, has just completed an outstanding piece of work, which is looking at CCOs 2.0 and what they need to look at, what they need to look like. I think universal care is something that, again, we're doing really well in this state in a remarkable way. I think the goal we have, the challenge we have in the current environment is to focus on the immediate challenge. And I guess that's going to be the Health Policy Board. I welcome you to bring that question directly to them. They're good at answering their own questions. But we're going to have to focus, the Health Authority is going to have to focus on the immediate challenge of retaining that Medicaid expansion, supporting our CCOs, and funding healthcare adequately in Oregon. I won't name them, but you all know the experiences we've had in Oregon where we've taken our eye off the prize, and it often produces challenges. And I'm not going to point to any IT projects. We are intensely focused on execution and the current environment, and we need to be at the time.
Thank you, Lynn. For our three CCO managers, leaders, each of you have slightly different models, balancing primary care and behavioral health, and even just your perspective on primary care supply and demand. It's been an important tool. Is it the future? What do we do about it? How do we balance it with behavioral? Where does that take place? What's your strategy?
I think, I don't look at primary care and behavioral health as necessarily needing to be balanced. I think they need to be meshed. I think that's really the answer in my mind, is these silos that we've built up, even within, we talk about the CCOs having sort of global budgets and having sort of shared experience and a direct goal. There's still far too many instances of, even within CCOs, the work being siloed. So here's the acute care side, here's the behavioral health side, here's the oral health side, and just all go off and do your own thing. That's not changing the cost curve. That's not changing the dynamics of a system that will help the business community and help us to say, how are we getting ahead of the game? So I think that more efforts we take to, one, having primary care is critical because you're getting folks the right care at the right time. But if you don't have that sort of coupled with the ability to access behavioral health issues, you're wasting your time and money on the primary care side. Same with a lot of the hospitals, and even on the specialty side, we've got some programs we're working on with behaviorists at specialty clinics, because if they're going through certain different instances of healthcare issues, if they don't have sort of their mind right, if they don't have the support they need, then they're not going to take their meds, they're not going to do their follow-up, they're not going to have that resiliency you need for them to actually survive. So, yeah, I don't necessarily see it as complementary. I think it has to be sort of one and the same.
Jeff, let me put a twist on that, both you and Chris. If we integrate them, we're also hearing in our provider community just the fatigue. Chris mentioned just the administrative load, the fatigue of the EMRs, and again, going to meetings all the time. And do we have time as we kind of jump curves to new models? How do we protect these folks and let them do what they need to do?
Well, first of all, I'll agree with Eric, and make a little bit different nuanced comment about it, and that is behavioral health is primary care for a lot of people. That's where they should be going first, not necessarily to a physical health provider. But you know, our primary care system in both in Oregon and across the country has been decimated to some extent. If you go back, and it's a long time, some of us remember the 60s, that you know, 50% of our physicians were in family practice, general practice, and so on. We're now down to 12%. And that's because the money has flowed somewhere else. We need to get the money flowing back into primary care, not only in terms of reimbursement for services, but we also have to do something about the high cost of education. So kids coming out with, you know, $250,000 to $300,000 in debt, which translates to well over $1 million in payback. They can't go into primary care. They can't afford it, so they go for the specialists. You asked a question about the number of meetings and
Burnout,
the number of,
right.
and the burnout for physicians. There's two parts to that. First of all, you know, the physicians of 50 years ago, you know, were dedicated pioneers, and they just worked 12 hours a day. Our society doesn't do that anymore. So people are spending more time with a work-life balance. I came from a physician's family, and I've seen that transition, and I think it's healthy. But I think we have to look, well, I know we have to look at how much we put on physicians and behavioral providers, anybody who's providing healthcare, about how much data, how many reports, and how much of a hassle it is to get things approved. They'd rather just practice their discipline rather than spend a half an hour on the phone with an insurance company, rather than having to fill out multiple reports so they can look good, you know, to a report by QCOR, and I'm not criticizing QCOR, but you all know how many surveys you get out of hospitals and doctors and all of that stuff. Think about what the physician has to put up with.
One of the unintended consequences of accountability. Yeah. Yeah, good. Chris, any thoughts?
Yeah, just maybe just reinforce the dilemma that you raised, Greg, that in our, I guess, neck of the woods, primary care access is such as much a vibrant problem as it was. Behavioral health integration, interestingly, you know, the champions in our community that really drove the early phases of integration are back at the table, ready to think about sort of this next generation. And while there's just energy around the topic, that there is a certain amount of weariness, to your point, probably accelerated by just the environmental uncertainty, particularly for the behavioralists. I think, you know, we hear stories about how their clients are reacting to the uncertainty around ACA, and as they look to care for their clients, it's having some impact on their thought about what do they put energy into going forward. You know, they're expecting and feeling sort of sea change, and that's having some influence then about how they put their shoulder into work right now. So I mean, there's great enthusiasm and a desire to build and progress, but sort of feeling like, boy, right now we're really living in a weird moment in time. And I think that's right now kind of a little bit of an impediment to moving the ball forward each day.
Sir?
Yes, I'm Chris Potter. I'm behavioral consultant at this point, but I'm going to follow up on that question, if I might, in terms of integration. Over the years, since the onset of OHP, we've had the carve-outs of behavioral health and primary care, trying to integrate those. But what I'm seeing is the payment structure, the fee structure, for example, is so different. I.e., for behavioral health, you still have you have to record every service to the minute, to the procedure, whereas in primary care, it's just the opposite generally. You do a procedure, you may charge by the doc, and then several other people may be working on that. What's being done to facilitate that kind of integration, to look at the fee structure so there's more ease in doing the integration instead of having these two very different, separate funding processes?
Any innovative ideas out there? Anything anybody's doing? It's different? Lynn?
I will say that that is an issue that has been identified we just completed a behavioral health collaborative of 50 behavioral health experts from around the state who worked for 7 months to produce a platform for improvement, and that's one of the elements of that work. I can't give you the timeline when we'll have it fixed, but it's on the radar screen, so that's always important. And I think there's going to be, we're hoping in March to bring forward the report of that collaborative, and I think that's going to initiate an effort across the state to do this work in a planned, full schedule. There's a deadline way.
Shojani, Nampa Community Care Organization. 5% of our patients are responsible for about 50% of our spend. And patients who've never had good behaviors in how to use healthcare didn't really know how to use services. And as we reach out to this kind of population, we need to re-engage patients with new behaviors that they need to learn. This is going to take time and a lot of effort and outreach and upstream funding. So our cost curve will only bend when we reach out to these 5% of patients that are really our biggest cost. So how can we convince the payers and legislature and providers of care to continue to focus on upstream funding and to be patient, because it's going to take time. So how do we convince that process to carry on? I think it will take several years. So that's my question.
Anybody want to jump into that? How are you going to convince? Does the question mean you need more time, you need more money? Convince them on what?
I'm not sure the statistics on where the spend is coming, they wavers around a little, but I think that if I understand the question right, correctly, don't want to use right and left here, that the real issue I think that society has to address is what's causing the demand out there. And we're healthcare providers. We're actually not the people who are set up to address the demand. What we get is the person who has a healthcare need that walks in the door, and we take care of them. There's been some talk about having us work with housing. Well, I would tell you that none of the three of us up here are housing experts. We don't know how to do it. And I don't know that we want to learn or that we should. But if you don't address the demand side of the thing, you're never going to reduce the cost of healthcare in terms of utilization. Price is another matter. thing I'd throw in just for the mix, and that is, we hear the term social determinants of health. I don't know who social is. We talk about education, we talk about poverty, we talk about environment, but I don't know who social is. I do know who the community is. And I call it community determinants of health because it really is our communities that are making the determination of whether or not our education system is up to snuff, whether or not our environmental laws are, and the places where people live are up to snuff. And it really is the community that has to pay attention to all of those things, where we have areas of poverty, food deserts, and so on. And you really have to energize everybody else, not just the healthcare leaders, to do this. And that goes back to our politicians, why we put up with food deserts in North Portland, for instance, or in Southeast Portland. Why our educational systems, we're building brand new schools on one side of the river and we're letting schools fall apart on the other side of the river. This all affects the health of the community. And then it falls in our lap and everyone looks at, what are you doing about it? I think we have to move our focus upstream as well.
Eric?
And I was gonna add, I think one of the things that we can do immediately, convincing them to give more time, to be more patient. I think as Lynn mentioned, patience isn't necessarily, that's not a virtue when you're talking about next year's budget. But I think there are things that we can do as CCOs and you all as members of the community and stakeholders is we heard about physician burnout and the lack of primary care. We need to try to enable those folks to work at the top of their license. So we need to redouble our efforts to make sure we get peer support and peer navigation, community health workers, and get folks who can be trained and educated to do some of that basic work and engaging and getting people where they need to be and understanding the system so that those physicians are spending time practicing as physicians, not doing sort of follow-up and making sort of routine phone calls. I mean, there's a way to get folks working at that most effective level for the system. So those minimal resources that we do have are used more efficiently. I think that's something that I think we can all really work on and actually do now and make an effort on. And then that will give you examples of, hey, if you do this, here are the incomes, here are the outcomes you have. And then ultimately, those folks that are the most expensive folks, palliative care, sort of end-of-life care, some of those things, there are some things you can do as well to keep folks going in and out of hospitals. And I think that's where housing comes in and partnering with housing services and Central City Concern and others can really make a difference.
But I'm going to excuse this next question if you choose. Excuse me? Yes, I will if you choose. Representative Greenlake's bill would substantially change the structure of CCOs. The Oregon Health Policy Board recommendations are more moderate to Transformation 2.0. Your perspective on these options, and again, I don't want to get you in trouble. So you can pass if you want, and I'll kick it to another colleague.
I'll give a short, quick answer. So I have profound respect for Representative Greenlake. When I grow up, I want to be Representative Greenlake and have the drive and passion for public service that he does. At his age, a lot of people are playing golf. So I applaud that he's taken on this policy discussion. We like policy discussions in Oregon, and it's going to be robust, and there are 90 legislators across the street from my office who are going to have that conversation. I don't need to weigh in on it at this point. If I'm asked questions for data, I'm certainly going to provide it quickly. The work that the Health Policy Board did was foundational in fostering the conversation. I think Dr. Robertson, Brenda Johnson, and Zeke Smith, our Health Policy Board members who traveled around the state and did that work, produced a very fine document. It's going to inform the debate. My principal concern as we go forward, and I learned a long time ago that from a very disciplined business person, Michael Powell, that the way to succeed is to focus. And we are going to focus on effectively landing the Medicaid expansion population successfully. And that's gonna take everything we've got. So I think there are plenty of people in this room who will inform that discussion. There's a host of lobbyists who will inform that discussion, and most importantly, the people of Oregon have weighed in on their expectations for CCOs. What I need CCOs to do is to deliver the results for the money that we pay them in a cost-effective, efficient manner, and to continually improve their game. And that's where I'm going to keep sharp focus.
Great, thank you. Any other panel comments? Jeff?
I don't view the Greenwood bill as being a.
And maybe just, some of you may need to know a little bit more about, in fact, what the bill does. Does anybody want to just give us a quick primer on that?
The quick primer is that it would make all of the CCOs convert to nonprofit. It would change a little bit of the governance, requiring more community members, and it would open up the meetings of the CCO boards as public meetings. Those are the
three essential elements.
And it would, there's also some things about having appropriate reserves that are controlled by the state. So those are the four major ones. You know, if we're going to have a policy debate, I would prefer that the legislature focus not on Medicaid and how to cut Medicaid. What I would prefer that they do is take a look at all tax-funded health care that is being delivered by the state of Oregon and put that together in a package and say, you shall operate in X form. Because like I say, I think there is plenty of money in the general fund and with the federal dollars that flow through for us to not have to cut expenditures in Medicaid. We could blend the PEP and OEB and Medicaid budgets together, and there would be plenty of money so that no one would have to suffer. The problem with that is that we have started to carve out and say, well, Medicaid needs to do this, while we leave, you know, other plans that are tax funded to go ahead and, you know, inflate at 6 and 7%. And I think that's the first place you stop.
Thank you. Any other comments? Chris?
I just echo what Lynn said about Representative Greenwood's passion for the topic and for the program and for progress. That's, you know, his passion and that of other leaders is sort of what's made this program progress and really lead the country. So also a big fan of his passion. You know, Lynn also highlighted the need to focus, and I think that again kind of gets us back to the, you know, what are we here to do? And I think a big part of it is, you know, the focus should be on the outcomes we achieve for the beneficiaries, the attributes of the organization. I think, you know, maybe are not the top of the page. And if, you know, if we keep outcomes for the beneficiaries as our point of focus, I think good things will happen.
Thanks. Okay, we've got a few minutes left. I want to remind everybody before we get up and leave, please fill out your surveys as your input helps guide what the health forum does next. And I'm going to do one last question and go down the line for each of our colleagues. And if you can, be pointed, be brief, be focused. President Trump has just appointed you Healthcare Supreme Commander in charge of all things healthcare. It's 20% of the GDP, again in Oregon, fourth highest state in terms of federal support. 25% of our population is on a federal Medicaid health plan. What would be your two top mandates or changes to the current system? Gail.
You didn't tell me to ask me that question.
Well, you know, this one came in from outside, so I had to. I didn't give them this one in the pre-meeting.
I think So I'm going to refer it on, otherwise I would just say you're fired.
Chris?
That's a tough one. I don't know this is exactly responsive, but I think one of the dilemmas we face right now is just this wall of uncertainty. Sort of with it comes a certain amount of paralysis around potential progress. So, I guess moments like this sort of remind me of the need for us to just in our daily lives kind of focus on what's right in front of us, and what's our immediate job. Because I think this uncertainty is causing a lot of either fatigue or distraction. I mean, it's good things to pay attention to, but I think we kind of risk a little bit right now in this period of sort of detracting from what do we need to do today, tomorrow, and the next day to deliver on the things we're responsible for. So I don't know if that's like simplify our lives or whatever the message is there, but that's kind of what sticks in my brain.
Very good. And I will come back to you.
Sort of way out there, the two things that I would mandate. Number one is that we take the prioritized list and add drug therapies to that area, and then mandate that it's used by all of the insurers in the state, so that we have a comprehensive evidence-based delivery system in terms of benefits. Now, I didn't set the line, but I think that's would be the best way that we could do that. The second thing I would do is I would focus on controlling prices of providers, particularly the two largest providers in terms of our budgets, and that's the hospitals and the pharmaceutical companies.
Thank you, Jeff. Eric?
My team's gonna say, they're probably cringing, saying, what is he gonna say?
They're right here in front.
Yeah, I know.
They're being honest.
I'm trying not to look at them.
They're staring you down.
No, I'll be probably more politics than I want to be. I think that the big things for me are, one, any efforts we can undertake to decouple healthcare from employment. I think that that folks shouldn't have to keep a job to keep their insurance, and so any efforts to do that, coupled with probably a basic guaranteed level of federal coverage. I think that means tested, so it's not crazy, but I think healthcare is a right. I think for me that's fundamental. So I think there should be some basic level of coverage that everyone has by virtue of being an American. And the structure that's used to enable that to happen is obviously up for debate. And the concept itself is, but yeah, I think those two things is making sure that people know that regardless of their employment or unemployment, their age, their status, that they've got coverage and the ability to get the care they need.
Thank you. Lynn?
First, I think Jeff and I have bonded over we are both the biggest, most passionate fans of the prioritized list, so we'll be forming a fan club in that corner, and you can be a charter member. Two things I do. Number one, I take on pharma. Number two, I re-engineer the country's health system for ROI on investments. That's it.
Thank you very much. One last question from the audience.
Yes, Jennifer Gonzalez, I'm with the Oregon RX card. My question is actually in regards to telemedicine. Are the CCOs starting to implement telemedicine for the future? I know that it's amazing to me in the younger population, the demand that they really have utilizing everything with technology. I don't know that even some of them write much anymore, to be honest with you. So, and this is real comments that I've heard from people. Are they starting to implement telemedicine? I know there's some HIPAA issues, but that's, starting to get solved. Is that something that the CCOs are doing?
Any innovations out there? Got a global budget? You'll do it if you wanted to. Is it working?
Well, I certainly can't speak for the other 15, and I guess just plain maybe
telepsychiatry in Eastern Oregon for many years, and it's highly effective. I've sat in on those sessions. It's pretty impressive. It is on our list of things to address going forward, again, for that ROI for the patients we serve. It's critical in rural parts of the state. It's critical because we're never going to have enough psychiatrists in the state for the size of our population, is my guess.
Right, Alaska's found a lot of success with that, so
Yep.
I was just curious.
Yep.
Thank you.
All right, anything else? Any last word? Well, let's give our panel members a Thank you all for being here. Fill out your surveys. Have a great rest of the day. Take care. Thank you.